whether the vitamin K antagonists are still the right choice in rheumatic heart disease, especially when you are looking at stroke prevention due to atrial fibrillation, and whether there are any answers or the take-home messages by the recent publication of a large study called the INVICTUS trial. There's no denying when it comes to the burden of the rheumatic heart disease, especially in the lower and the middle income group countries like ours. A large population is affected with rheumatic heart disease. And when the rheumatic heart disease is associated with the atrial fibrillation, it inflicts further increase in the morbidity and the mortality. And the only way to prevent the occurrence of the morbidities and mortality due to the atrial fibrillation is the administration of the vitamin K antagonists. But vitamin K antagonists are difficult to practice. They have lots of dietary and pharmacological interactions, and they need a strict monitoring of the INR. The education level, the economic costs, the scarce health resources in the countries like the study population makes only a few percentage of the patients who actually require the anticoagulations are being considered, and many of them are not actually in the therapeutic range of the INR. So with these issues, what comes to mind is we do require an anticoagulant that does not need monitoring, which does not have less interaction with the diet habits and drug interactions. And when these things come into mind, another drug comes into mind, and that is the direct oral anticoagulant. Indeed, there is a growing interest for the DOACs in rheumatic heart disease atrial fibrillation. That's not new. In fact, that's going on for the several years now. Even though we believe that the newer oral anticoagulants are not used in valvular heart disease and only the VKAs are used, it is not true, because even in RHD, DOACs have been used, especially in the regurgitant valves, bioprosthetic valves, both at the mitral position and the aortic position because of the rheumatic heart diseases, and recently even in TAVI. Where the DOACs have not been used because of the exclusion of the candidates in those pivotal trials is those patients with the rheumatic heart disease who have had metallic valves and moderate to severe MS. So it is not that the DOACs have not been used with the rheumatic heart disease and valvular disease. So there had been an interest in the minds of the investigators to look for the DOACs, specifically in the excluded population with moderate to severe MS and metallic valves in rheumatic heart disease. If you look at the pivotal trials, all of them, there has been from 13% to 25% of the patients included in those studies have had varying degrees of rheumatic heart disease or a valvular heart disease. What was that is excluded was the metallic valve processes or severe or moderate mitral stenosis. And DOACs in those rheumatic heart disease cases fared equally well as compared to that without the rheumatic heart disease or valvular disease. And recently, there was a further impotence to the interest of using DOACs in rheumatic heart disease and significant valvular disease when they underwent correction with the bioprosthetic valve, either at the mitral position or in the aortic position. Look at this slide. Rivaroxaban specifically was found to be non-inferior to warfarin with respect to the primary outcome of systemic embolism or stroke prevention. So this, I think, led to the carrying out the experiment in the rheumatic heart disease population. There's one more big reason why the investigators thought that DOACs should be considered aggressively in severe mitral valvular diseases, because if you look at this national trend in the use of the direct oral anticoagulants in US, whether it is the mitral or aortic wall, and when it comes to the prosthetic walls, either at the mitral and the aortic wall, large number of US physicians have been using DOACs, and surprisingly, off-label use of the DOACs is steadily increasing. Up to 2% of the US physicians are now using DOACs even in aortic as well as mitral metallic walls. Because there was no randomized controlled trial of comparing the VKAs versus the DOACs, the INVICTUS study was thought of. It is a fairly large trial, INVICTUS study, over a period between 2016 to 2019. 4,565 patients affected with the rheumatic heart disease who have had moderate to severe mitral stenosis with a high risk for stroke or a systemic embolism in the form of a CHA score of 2 or more, or the presence of spontaneous echo-contrast in the echo or the thrombus, were included in a multinational, multi-center format across the globe, 24 countries, 138 sites spread over Asia, South Africa, and Latin America. And they were randomized 1:1 with the rivaroxaban versus vitamin K antagonist. Rivaroxaban was given 20 or 15 milligram once a day, dependent on the renal function, and VK were administered meticulously maintaining the INR between 2 and 3. Point to be noted here that the cohort was comprised of a quite younger population. The mean age was about 50 years, and 75% of the patients were women. The follow-up was median 3.1 plus minus 1.2 years. Now, the study was basically to look at the benefit of the DOAC or the VKA in the management, in the prevention of stroke or thromboembolism. And hence, very correctly, the investigators thought of holding the primary outcomes as the composite end of stroke and systemic embolism. And the investigators thought during their so-called period of study, they would get about 1,079 events with a power of 80%. Very well thought. But as the trial progressed, they realized unexpectedly there are very, very few stroke or systemic embolism. And hence, they included in the primary outcome several more issues which got them into trouble. As I progressed through to my talk, the analysis become really very complicated. So in addition to the stroke and systemic embolism, investigators included certain other primary outcome endpoints, and they were MI, death due to vascular or unknown cause. So any death could also be included as a primary outcome, so that they will have more number of events. Of course, the primary safety outcome has to be the major bleeding. Let's look at the compliance issue with respect to these two agents. Very unexpectedly, the vitamin K antagonist compliance was very high, near 100%, throughout the study period, whereas the compliance became less and less and less as the study progressed, and at the end of the 4th year, there were hardly 80% who were drug compliant with respect to rivaroxaban. Another unexpected finding was up to 65% of the patients with the VKA remained in the TTR, and that was very surprising. 65% of the patients had their INR between 2 and 3. That's commendable. Now let's look at the outcomes. Again, I repeat, the primary composite was not simply the stroke or a systemic embolism. It included death due to any cause, vascular or unknown cause. If you see here, there had been a significant increase in the primary outcome in rivaroxaban, 560 over 446. And that, if you look carefully, it is not driven by the prevention of the stroke, because the ischemic stroke were very little more in ischemic stroke, but they were not the driving point with respect to the primary outcome. So it was the death which was significantly more in the primary composite endpoint, but not the stroke or the embolism. That means the VKA actually did not prevent these primary outcomes by necessarily reducing the stroke and the embolism. Intention to treat and on-treatment analysis showed similar results. Significantly high mortality in a rivaroxaban group was really, really unexpected for the investigators, and they started looking for the explanation, which they found it very difficult to explain. They tried to figure out, is it because the VKA group had more physician interactions, whether the patients actually came more often to the clinic in the guise of monitoring the INR, and during that time, they were evaluated more thoroughly, and maybe the death was prevented because of the more frequent interaction with physicians. They also kind of considered whether it was a less compliant feature in the rivaroxaban group as the cause of the difference in the primary outcome points. However, it was very clear it was definitely not related with the reduction in the stroke or a systemic embolism by the VKA. And it was also made out that it was unrelated to the progression of the valve disease. Whether the patients on rivaroxaban, did they have a rapid progression of the rheumatic heart disease, valvular disease? It did not appear like that to the investigators, because those patients during the follow-up went to the mitral valve surgery or a mitral valve repair. That number remained same in both the groups. So it is not a differential effect of these drugs on the progression of the disease. There are some interesting facts about this Kaplan-Meier curve of this INVICTUS study. What is noticeable here, till 18 months of the follow-up, there had been no change in the primary outcomes. But as the follow-up increased by 4th year, there had been a significant divergence among these two curves. So what is that is happening, which was not happening till 18 months of age? We know that the VKA did not reduce the mortality because of prevention of the stroke. We also know that the VKA did not change any disease progress, because both the groups had the similar rates of mitral valve repair or surgery. There is something which the investigators are unable to tell us very clearly. So it is independent of the prevention of the stroke and may not be the valvular pathology. Maybe VKA has some other feature which helps in general the protection among the patients with rheumatic heart disease, but the mechanism is not clear. So what does INVICTUS tell us after all? In RHD and moderate to severe MS and AF, compared to rivaroxaban, VKAs reduced mortality very, very significantly. Less ischemic strokes, and hence INVICTUS investigators recommend that we continue to use the VKA as the standard of care, even though they admit the mechanism of the benefit is not clear to them. Is it the end of the road for the DOAC? Not necessarily. Still, there is an interest by the investigators in the DOAC. Maybe we require more trials, more observations, more registries, and to aid that concept that the DOACs could be still used, there are two ongoing trials. One is David MS, moderate to severe rheumatic mitral stenosis, using dabigatran versus VKA. And there is another one, PROACT 10A, which is the mechanical aortic valve prosthesis. And the same investigators are going to be recruiting, which is in the trial. It is at the metallic mitral prosthesis. So with these words, I would like to say the INVICTUS had made us to think more about the benefits of the VKA, why is so, and maybe the DOACs have not seen their end of the road in their journey. Thank you.